morning, everyone. Hopefully everyone can hear me online. And we will go ahead and start our grand rounds. First one in February of 2024. And again, for those of you who can't quite see me, I'm Dr. Williams, Chair of Medicine. And it's my distinct honor this morning to introduce to you Dr. John B. Harley, who is an amazingly accomplished rheumatologist. And he comes to us from Cincinnati, but he started his training really at Dickinson College in Pennsylvania, and then went over to become a Pennsylvania Quaker, where he did his MD and Ph.D. He traveled around. He's trained in a lot of places. He told me to remind you that he trained with Anthony Fauci, but he's done a lot more than that. Okay, he actually was at a variety of institutions, including after his time at Penn. He was a Yale Bulldog for a while, and then he was an Oklahoma Sooner for a while. And he finally settled after a long career as chief of rheumatology at University of Oklahoma. He actually spent a little bit of time actually in industry, okay, and concurrently, and then working his way back to full-time academics at University of Cincinnati, Cincinnati Children's Hospital, and particularly his service to our veteran population at the VA Medical Center in Cincinnati, Ohio. He is a professor of pediatrics and medicine, and he is a very widely published, hundreds and hundreds, 543 publications, and they're in a variety of areas, but his area of interest and his talk today are very close to my heart, which is lupus. And as you know, we've spent a lot of time working on health equity issues, and I'm sure everyone knows that our African-American population has about a ninefold increase in this particular disease. So anything that we could do to try to help with that would be helpful for our community. And so the title, Lupus, EBV, and Multiple Sclerosis, we're so welcoming to have you here, and looking forward to all that we can learn from you.
Yeah, well, thank you, Dr. Williams.
Absolutely.
All right, well, I have a rather informal presentation style, and I'm delighted to be here and to talk to you all about lupus and where it comes from, and how we think about it, and some of what we're going to do about it. So I'm obligated under our current way of operating to tell you about my conflicts of interest and disclosures. And of course, there's a lot of off-label therapeutics used in lupus, so you can see the list here, and we'll talk about those in a little bit. So, I'm going to do the clinical findings for the generalists and the students and the residents to begin with, and then we'll talk a little bit about the therapeutics, and we'll end up hopefully with talking about the etiology. And so my story is I had a really good friend who was had been a medical student and then an incredible investigator, who, as a third-year medical student, I went to see in the hospital, and he died when I walked into the room with he and his wife there, and lupus renal failure and cardiac failure and whole system shut down. And so at that point at the University of Pennsylvania, Arnold Relman was chairman, who became editor of the New England Journal. And there were 4 individuals who were either previous chiefs of nephrology at other institutions or there, and nobody knew what to do for him. And so he died at the age of 32. And I said, well, shoot, I'll just see if I can figure out where this comes from. And so I think I know now. And now the issue is just, before we kick the bucket to figure out, to prove it to everybody else. And so that's what I'm going to tell you about. So in the beginning, this is a patient that we saw in Oklahoma. This is a Mexican immigrant, female, illegal immigrant, who presents to the emergency room with lethargy, disorientation, a symmetrical polyarthritis, a maculopapular rash on her orange chest space, multiple bruises, had had a fever of 102 for a week. Her family finally brings her in, and she cannot produce a urine sample. And so you know what happens to this patient. She gets stuck in the emergency room for a few hours, and her situation deteriorates. She gets a lot of attention when she has a seizure, and she's hypotensive at that point and is still making no urine after 6 hours. And she goes on to have a cardiopulmonary arrest and dies at the age of 16 in our emergency room, which is a sad thing to happen. And especially with a disease like this that we can make a big difference for. And so there's like 500 different things that you can come to the emergency room and die with a fever. And this list is one of those diagnostic challenges to figure out where this comes from. And of course, this patient had lupus and didn't have Behçet's, Kawasaki's, Takayasu's, good pastures, multiple sclerosis, ulcerative colitis, familial Mediterranean fever, or any of those other things you see here, or an infection or an allergy. And so I told Dr. Knight I'd show data from Johns Hopkins, where he was a long time ago. And this is the data that they show in 1953, that the average lupus patient has a life expectancy of 4 years. The average patient is a 32-year-old woman. Just a drive-by autoimmune shooting that spins out of control. If you read the old literature about this disease, these patients just get worse and worse and worse. And in those days, there was nothing to stop them. And then with the discovery of steroids, we did a little bit better. And then with cytotoxic therapy, we start to approximate what we can do today to control this disorder. This is the image from von Hebra's textbook. Von Hebra was this really incredible physician working in Vienna who hired this artist to work with him, and he published a textbook of dermatology in 1856 that is absolutely spectacular. And this is what we think is the first known image of someone with lupus. She has the classic malar rash up over her nose, and was referred from the Dutch lowlands to see him in his clinic. And of course, he couldn't do anything for her. And we don't know what the clinical outcome was for this patient. This is from the 1901 series put together by Sequeira and Balin. And this young woman is 19. She lived 2 weeks after this picture was taken. She has the malar rash, had all these things that you can see on the right: headache, abdominal pain, peripheral edema, hematuria, granular cast, pleural effusion, and pulmonary infarction. And so she was a London stationary folder and was part of 101 patients that they presented at that time, in the process of turning this, what began as a dermatologic condition, into a systemic disorder. So the thing that about half the lupus patients get is kidney disease. For the students in the audience, this is what a glomerulus ought to look like. And when you have aggressive lupus, this is what the glomerulus looks like. You might outline the micro anatomy of a glomerulus, and you can see that it's full of cells. There's no way urine is being made or filtered in this glomerulus. And the astonishing thing is that if you treat this aggressively with immunosuppressives and do not lose the microanatomy of those glomeruli, they'll come back and work again. And so that's turned things around incredibly in the early 80s. This kind of therapy was being used and is astonishingly effective. These are some of the findings in lupus. You see the photosensitivity on the upper left with a malar rash, another malar rash in the middle, the immunofluorescence of complement being deposited in the glomerulus in the middle, an African-American man with the rash going up over the bridge of the nose. And I don't know if you can see that these folds nasolabial folds are generally spared. It's one of the classic kinds of findings with this kind of malar rash. If you see a patient with this kind of rash, lupus should be the first thing you think of. It's almost pathognomonic, not quite. Oral ulcers are also characteristic, and this area between the hard and soft palate is considered classic. Patients get a symmetrical polyarthritis that I'll come back to. About 87% of patients will have the polyarthritis. And of course, virtually all the patients will have a positive anti-nuclear antibody as measured by one of a myriad of different ways we can measure this these days. And then there's all kinds of other rashes that patients can get, and I'll start showing you some of them. This patient has subacute cutaneous lupus. The fluorescent lights in this room are enough to make this rash worse. You can't examine this patient in an ordinary exam room without making that rash flare up. And you can see that there looks like there are all kinds of different ages of this rash. And classically, these patients would have the Rho or SSA and La or SSB autoantibodies. And often they'll have, they may have a high level of those antibodies, enough that they have a cryoglobulin, and they may have the disease confined to the skin, which is good. Now, I showed you an oral ulcer before. This is an oral ulcer for the dermatologists because there's no there's no covering left in this mouth. It's a really bad oral ulcer. And I had also shown another slide of the earlier view of what the polyarthritis looks like. In this patient, you can see the polyarthritis has probably been there for years and persists. One of the characteristics in lupus is that the bones and cartilage are usually left intact, and you can reduce the deformity. Whereas that's not always the case in rheumatoid arthritis or psoriatic arthritis. Those diseases can destroy the cartilage and bone as well. Lupus tends to be something that you can reduce. So now I'm going to show you a bunch of the different ways the malar rash may appear. And so here's a young girl who has a rash. You can also see a little bit on her chest and her chin and her forehead, but she's sparing the nasolabial fold. This young lady has ulcers inside her mouth and has a rash on her face. And look at this one. Isn't this interesting? This woman has this rash. She's smiling. The rash doesn't really bother her. Patients don't scratch this rash. It doesn't itch. And so there must not be a lot of histamine being released. And you would expect that they had a rash with friable skin like this, that there'd be a lot of destruction of the skin, but that isn't the case. Here's a young man. Men are 1/10 or 1/10 the frequency of lupus, and the basis for the difference in the sex prevalence is something that is a major issue at the moment, with lots of different ideas about where it's coming from. Our data, we were able to show that Klinefelter's men have the same frequency as women do, XXY men. And so that plus other data suggests to us that we have a gene dose effect happening. And then the other side, the lecture I'm not going to talk about today, is the genetics. And so the variants on X so far do not provide an answer for what that sex difference comes from. This was one of my patients who you can see she tends to completely spare the nasolabial fold, and she developed the CNS lupus about 4 or 5 years after this and died. This patient is at presentation with this malar rash, and so she's pretty classic with how the rash appears. And I've pointed out the spot in which the biopsy of her skin was taken, just so that you can be convinced that it's the same patient in this slide, who after she's treated, she has the positive makeup sign that she's doing better. And here's a patient that I saw as visiting professor in Ontario, and she has the classic appearance for aggressive discoid lupus. So you can see there's a central area of necrosis right there, and then an area in which there's the skin is coming apart, and then a halo of inflammatory inflammation around it. And so finally, discoid lupus has therapies that look like they work pretty well. So that's a big advance. And this is a slide showing the perivascular infiltrate kind of vasculitis at a biopsy site with discoid lupus. One of the mystifying things is how the alopecia happens. Lots of patients will lose their hair, and this is an old lesion in this patient of discoid lupus, in which the skin is now healed, but the follicles have been destroyed. And this is the same patient showing patchy spots across her scalp, which were involved. And another patient. So I've seen patients whose discoid lupus is kind of burned out, and they are confused. Those patients are confused with patients with vitiligo because of the loss of pigmentation. This young man has one discoid lesion on his face, and as already been mentioned, African Americans have between 4 and 6 or 7-fold increased risk. It's estimated in, I think it was San Francisco, that 1 in every 148 women in that community had lupus. And the alopecia also tends to make the hair fine globally across the scalp. This lady has a rash that you can see. It's kind of subtle. And sometimes in someone who comes to talk to you and says, well, I had lupus and I was treated and this and that happened, and that was 10 or 15 years ago. And you can see on their face that they have atrophy in the areas in which the rash was previously present. It's a little bit of a clinical pearl to use to help convince you that maybe that was really true. And have a variety of rashes. This is a rash that would easily be confused with pemphigus-like illness, but this patient had anti-Ro antibodies. I've only seen 3 or 4 of these in the thousands of lupus patients I've seen, and all of them have had anti-Ro antibodies. Lupus is an intravascular disease, and when the blood doesn't flow, the tissues that are fed by it die, and this patient has necrosis at the tip of her finger. This patient has serositis with a pleural effusion that is easily appreciated in the right chest field. And lots of patients will have CNS problems. If you're a rheumatologist, the ordinary experience of a rheumatologist is that you go into practice and you just fall in love with your rheumatoid arthritis patients because they're salt of the earth. They're reasonable people, and they're so easy to take care of and so appreciative as a group. And then the lupus patients tend to be neurotic. And so many investigators rheumatologists will try to avoid them, and the patients with fibromyalgia and a positive ANA who flow into lupus clinics. But these patients really have serious CNS problems, and taking care of them can be quite a challenge, especially if they happen to be a doctor. Then they think they can take care of themselves. And so I've had a few patients in my career who were young women residents or fellows, and who would then use poor judgment in terms of what they would do for their therapy. And some of them actually died because they couldn't follow medical advice. And there's no way to force them to do that. And so we don't understand CNS disease very well, but it is a big problem. The classic spectrum of what lupus patients present with is so varied that you can have 3 or 4 patients that share nothing except the positive anti-nuclear antibody, for example. And so these are the old-fashioned classification criteria that the American College of Rheumatology for the purpose of classifying patients, not a diagnosis, but in order for the studies that were done by dermatologists versus nephrologists versus rheumatologists to be comparable. And so if you had, in the old days, if you had 4 of these major things without a better excuse for presenting them, then classify a patient for a study as having lupus. And so I've presented most of these things as I've talked so far. I haven't talked very much about the hemolytic anemia or the leukopenia, the thrombocytopenia. They're pretty classic. You can have, if you have thrombocytopenia, that is, as a patient presenting with thrombocytopenia needs special attention, because that is a signal that the prognosis for death is high. Up to some studies, up to 7-fold increased risk for dying with patients that present with thrombocytopenia. And then there are classic serologic changes. I'll come back to some of them. Anti-double-stranded DNA is almost pathognomonic, as is anti-Smith. And then there are the anti-phospholipid antibodies and the anti-phospholipid syndrome that can present explosively with multiple clots and just unable to turn that around. And it can be a really difficult time. And so probably the first test that was positive is the false positive VDRL, which the VDRL was developed about 1910. And the period between 1910 and the development of the anti-nuclear antibody, the false positive test was the only test that showed up, and trying to clarify this disease and separate it from all the other inflammatory diseases that weren't understood was a big challenge. This patient, of course, is having necrosis of her finger because of the involvement of the our arteries feeding that. This is Liebman-Sachs endocarditis. We don't see this anymore, I think because lupus is much more aggressively treated, but longstanding lupus, these lesions formed in many patients in the decades past. This is Raynaud's phenomenon. Maybe you can't see it so well, but in the original, this part of the hand is erythematous, and this is completely blanched. And so this is the way that they present. There's a lot of patients with Raynaud's phenomenon. And so the autoantibodies are central to the diagnosis. And in our opinion, also important for pathogenesis. When I started this trek a few decades ago, it was a popular controversy whether the autoantibodies were just epiphenomenon and really didn't have much to do with the disease origin. The first autoantibody was discovered at the Mayo Clinic at about the same time steroids were discovered in 1948. This is the LE cell. This is a polymorphonuclear leukocyte who has ingested the nucleus of another cell and is in the process of digesting it. These are autoantibodies as measured by the Octrolone test. That's agar, which is like Jello, with serum here, and calf thymus extract here. And when the antibody meets the antigen, it forms this line. That's one huge immune complex that shows the anti-SM specificity and the line of partial identity with what's now called anti-nuclear RMP that was worked out in the early 70s and separating these two. This is from Mo Reichland, who was my chief in Oklahoma when I started my academic career. And he published this paper in about 1963, I think. Okay. And so these assays have been replaced by far more sensitive solid phase assays, which were classically ELISA assays first, and then a whole variety of different ways that the same sort of strategy is followed. But the anti-nuclear antibody is the classic test. And while it's being replaced by multiple antigens on a solid phase, this is what the homogeneous nuclear pattern looks like. That tends to be histones and chromatin. This pattern is a cytoplasmic pattern that sometimes anti-Rho patients have. And here we have homogeneous nuclear speckled and nucleolar, and then a centromere pattern, which is classic for CREST, the variant of systemic sclerosis that is actually a different disease. Here's another nucleolar pattern, and the anti-nuclear antibodies are present in virtually all lupus patients. If you do not have a positive anti-nuclear antibody, you need to think seriously about whether or not you really have a patient with lupus. And these other conditions listed here also are positive, but one of the important things to remember is that normal women can be positive, depending on the lab, from 5 to 30%. And so it's important not to overinterpret that result. And most rheumatologists who concentrate their practice on lupus in a referral way need to cope with all these anti-nuclear antibody positive people that are sent to them by primary care physicians for evaluation of positive lupus. And so there's some clinics that will take fibromyalgia with a positive ANA and call it lupus. And you'll see these patients coming to you who've been treated with cyclophosphamide and other chemotherapeutic agents that look like it's a little bit overboard, if I can be modest about that. And so please be on the lookout for that kind of thing happening, and do your best to discourage it. These are octolonies of various autoantibodies. The P autoantibody is associated with mental illness in teenagers. And of course, teenagers, as I presented in the beginning, can have the most aggressive disease. When their immune system is turned against itself, they can be incredibly destructive. So I'm changing the subject just a little bit. This is neonatal lupus. So this child, hello? Huh?
Someone was just like, oh.
Yes, this baby has this rash. And so a very good dermatologist came and said, oh, this is neonatal lupus, and it's going to go away. No need to worry about it. As soon as the mother's antibodies are metabolized, this rash will disappear. And so this is a result of pumping anti-Rho antibodies across the placenta into the baby's circulation. And so you don't worry about this, and this child is older, and you can see the pigment has been removed from the upper eyelids, and but that'll come back. And so these patients don't have any residual of what happens. You just
mom not breastfeed though? Is she still gonna be given antibodies?
she could, but in the baby circulation, the antibodies don't cross the GI tract. The antibodies, the important antibodies, are in the circulation, and those get metabolized in the first 6 months. But what you're worried about is neonatal lupus that presents as complete heart block. And so this happens in about 1 in 50 anti-Rho positive patients. And you can see I've marked with a little green triangle the P wave, and you can see the P wave marching across the QRSs at a more rapid pace. I once made the diagnosis of neonatal lupus in a medical student who had a physical exam, and he was asymptomatic, except he couldn't run very fast. and in Oklahoma, and his mother, his father died, and his mother went to Florida, and she had an anti-Rho classic rash after she decided she wanted to be a sun goddess in Florida, and had all kinds of sun exposure, and then that brought forth lupus 32 years later. So we published that case. Anyway, this can be dangerous. These babies can die with this. So knowing it's happening and there's some evidence to suggest that treating with steroids that make it across the placenta works if you see first-degree heart block coming along. There's a big controversy about this in the and what to do about it. Joe Biden in New York is leading the effort to try to understand what to do and how to deal with it. So I've already talked about the ELISA assay. I will not go through the details about how this is put together, but these assays transformed the ability to be able to identify these patients and to figure out what their antibodies were. And we have all kinds of antibodies. Some of them are very specific, like double-stranded DNA, and others are non-specific, like single-stranded DNA and rheumatoid factor. Rho and La tend to be, you can be asymptomatic with those antibodies and be asymptomatic for life, for that matter. And then SM and P are almost pathognomonic for lupus. And if you find the lupus anticoagulant or the antiphospholipid antibody, then you need to be careful about clotting and recurrent miscarriages and those kinds of problems. There's probably 100 now. The history of therapeutics for lupus is pretty interesting. Aspirin, which we wouldn't use these days very much at all, was the first drug approved in 1948. And then anifilumab is the last one, 2021, and voclosporin. So belimumab in 2011 is for pretty active disease, and hydroxychloroquine, which used to go by the is now generic, but went by the trade name of Plaquenil. Many rheumatologists considered it vitamin P because we have a lupus patient controlled with mild lupus with hydroxychloroquine, and then they'd stop, and 3 or 4 months later they'd be flaring with disease that was out of control. And so you see a lot of that. We use a lot of things off-label. Mycophenolate is a wonderful new tool in our armamentarium. It's replaced the use of cyclophosphamide, which we used to use a lot, and of course has its major dangers and side effects. And azathioprine has been pretty useful. Azathioprine is recommended for lupus patients who are pregnant as an alternative if immunosuppression needs to be maintained. Thalidomide is extremely useful for discoid lupus, but using it, as you might know, with all of its troubles, is a really big problem, especially in a reproductive age female. And tafasitamab looks like it's going to be promising for discoid as well. For desperate, lupus patients present like the young girl I presented at the beginning. That situation is desperate. If you don't turn that around, that patient's going to die, as happened in our emergency room. And so autologous and allogeneic bone marrow transplants have been attempted. Autologous is you kill the bone marrow with usually cyclophosphamide and allow it to recover. And then allogeneic transplants are for desperation situations in which you cannot control the disease. And so these days, with the tools we have in hand, are very rare. And this is from the data here are actual numbers from a large consortium of European rheumatologists. So this is the kind of therapy that is reserved for the really rare patient. The big buzz in the American College of Rheumatology was the CAR T therapy. And I'm going to go ahead, take your picture. I'll send you the slides if you want them. And this paper came out a little more than a year ago, in which they treated about 5 patients with this unbelievable vector that was directed against CD19, but the vector is a mosaic of different pieces. they have a CD19 antibody and a CD8 hinge region and a TNF RSF19 transmembrane domain and a CD3 zeta intercellular domain and a 4-1BB co-stimulatory domain, all put together into one piece. And then the T cells are taken out, they're infected with this and then reinfused. And these patients had a remarkable recovery. So these are desperation patients. And this therapy, basically at the point of presenting this, almost like 4 out of 5 of these patients look like they may have been almost cured of the disease. So there's a huge interest in following this up for patients of desperation and figuring out what we do with them. I'm sure you probably have some of those, given the community that you serve, you probably have an occasional patient that is in which the situation is pretty desperate with lupus. The only one, this one patient whose anti-Ro antibodies don't go down to 0, that patient may have some substantial residual even after CAR T therapy. So now I'm going to change the subject to what causes disease and what I've been focused on in my academic career. And to save you all the trouble of going through the 543 papers we published, this is the model for what we think how lupus happens. We think that in general, for about 90% of the patients, they get an Epstein-Barr virus infection. Everybody in the room is probably infected with Epstein-Barr virus. We're all infected. And once infected, we're infected for life. The infection's active. We have transformed B cells that, if our immune system got lazy, would turn into a multifocal lymphoma and kill us, like it does with the Burkitt's lymphomas children in Africa. And so EBV is a lifelong herpes virus that infects B cells. It hides out in the memory B cell compartment and slowly comes back to life. About 10% or a little bit more of the population is infected at age 10, and over 90% is infected at age 20. And so this is why we see mononucleosis in the teenage years. And if you get infected with EBV as a baby, you're asymptomatic almost. But the immune system is in a different place when you're a teenager. And then I think what's happening is that EBV is really unusual. It will actually stimulate the interferon response. And I think that's responsible for the incredible fatigue that people have with mononucleosis. Anyway, that's off the subject a little bit. This section is about the genetics, with Epstein-Barr virus nuclear antigen number 2 being deeply involved with the transcription factors that change the metabolism of the B cell. And so I don't have time to talk about that, but this is the antibody system. We think that anti-EBNA1, which is the viral product that attaches the virus to the chromosome, is the antigen from which the lupus autoantibodies are generated. And then you have a cross reaction that then results in time with this disease presentation. And so we were able, out of a set of strange circumstances, to learn that the US military had this huge serum bank. And so we went into the serum bank that the military has. They now have 60 million serum samples in this bank that's kept just outside of Washington. I'm funded to do another study in that bank. But we could go before lupus patients got sick and look, as many as 10 years earlier. And half the lupus patients have positive ANAs 5 years before diagnosis. And so this paper is probably the paper most cited in the work that we produced, and is convinced the community that the autoantibodies, since they precede the diagnosis, are probably not epiphenomenon. And it looks like lupus patients accumulate antibodies, and then when the diagnosis is made in almost any therapeutic is attempted at all, then you stop accumulating new autoantibodies. Anyway, we'll come back to this in a little bit. The different specificities have different times of appearing, and you can see that anti-SM and nuclear RP are the ones that look like they show up very close to diagnosis. We use this peptide synthesis technique. My PhD is in biochemistry, so I never believed the mantra of linear epitopes that the immunologists carry around. And you know, everything is always three-dimensional. And so we were able to put together a system in which low affinities could be concentrated and taken advantage of the two reacting centers on antibodies in IgG, for example, and multiply the affinity to be able to detect even components of what those structures were. And by making the peptides so thick, they're like a field of corn on the surface of a piece of plastic. And we were able to make, here we go, assays that could distinguish individual peptides on these structures. And so we identified the first structure, and that's in the SM system, that's PPP-GMRPP, proline, proline, glycine, methionine, arginine, proline, and glycine or proline again, and show that all the patients that develop this do it the same way. They start with the same structure, they go to the same second structure, they go to the same third structure, and then it spreads all over the molecule. And then we realized that this had a cross reaction with Epstein-Barr virus nuclear antigen number 1, and could take the peptide from the virus or the SM and induce lupus in animals and show cross-reactivity. And so we could do the same thing with anti-Rho, but this time the sequences were different, but they satisfied the immunological criteria for cross-reaction. And so without going into the detail about how this is established, we were able to immunize with this also and create a lupus picture in this rabbit that we published some time ago. And this rabbit died with alopecia because it developed, isn't that something? The rabbit died with a bezoar. So it had so much hair loss that it ate the hair and it blocked its GI tract. Yeah. And so we think that because of this kind of work, that the anti-EBNA1 cross-reaction is the origin of autoantibodies. And so we have a number of papers about that. And we were able to show that EBV was related. There are now a number of meta-analyses that support this, that Epstein-Barr virus infection in adults and children. In children, you can get because the controls are lower, you can actually get a pretty good odds ratio. The odds ratio here is like 50. It's a huge difference. And so looking at the cross reactions, we have evidence for cross reactions with Rho, with SM, and there's other data about C1q and SMD, and perhaps there's an implications for double-stranded DNA. And so the controls make anti-EBNA1 that don't do this, and that looks to us as what the origin is. And if that's really true, then scientific hypotheses are useful when they make predictions about something you wouldn't expect. And then if you can prove that prediction, that increases the likelihood that the hypothesis is correct. And so the idea here is that anti-EBNA1, we think, is the origin. And so if you look at the population, is that big blue blob, the about somewhere between 70 and 90% of the population will be anti-EBNA1 positive. And you ask the question, where do the lupus patients belong? They don't belong in that spot in the center that's white, with EBV people, that a few people, like 2 to 5%, that are EBV negative through life. do they belong in that yellow where they have the same distribution of anti-EBNO1 as found in the controls? And so we've tested that. And what we've learned is in 2 studies now, this one we published 2 years ago, and one we published before in children and in different ethnic groups, that the anti-EBNO1 conforms with that prediction because the lupus patients have a 90% or better, 90 to 100% predictive value for having anti-EBNO1. And so it looks like that comes with the requirement to have disease. And so here's a pooled analysis of those 2 studies with an odds ratio of about 14 and a powerful positive effect. And so we conclude that the lupus patients belong in the blue. They don't generally have, are not anti-EBNO1 negative, and it's supported, that prediction is supported by experimental data. It doesn't establish that lupus comes first or EBV comes first. And so the interesting way that this was addressed in another disease in which EBV is thought to play a role is in multiple sclerosis. And so EBV has been suspected for multiple sclerosis for a long time. Mononucleosis raises the risk of multiple sclerosis 2 to 7-fold. And so I have a lot I could talk about that, but time is limited. So the idea is you take an exposure window before disease onset. And then in the absence of a better explanation, if you can show the exposure during that time is higher, is more frequent than it is in controls, you can conclude that you have epidemiologic evidence for etiology. And so this was done using the repository that I talked about before, of the military, looking at multiple sclerosis patients before the onset of disease. And so the finding in this paper published now 2 years ago, this month, shows that that's true, that the multiple sclerosis patients have a higher conversion from EBV negative to EBV positive than do controls. And so this has been used to establish etiologic causation of multiple sclerosis by Epstein-Barr virus. And so in unpublished data, using the same military serum bank, we have the same kind of data. It's not as convincing as their data, and it's preliminary. It's the basis for the merit award that I was just given to establish this in spades. If it's true, then the controls are on the green line. They're going from anti-EBNO1 negative to anti-EBNO1 positive. So now we're looking at EBV infected people who do not have the anti-EBNO1 antibody at the time they are brought into the military. That first serum sample is EBNO1 negative. And so they're all EBV infected. And so the lupus patients are in purple, and they develop the anti-EBNO1 first before the controls with an odds rate, with a hazard ratio of 12 and a p-value of 10 to the -4. And so that's after controlling for sex and ancestry and all that stuff. So we need to do this in a larger group. If it's still true, then we will be able to establish the on the same level that multiple sclerosis is established. And so this rejects reverse causation. You can't have, you don't get lupus first and then anti-EBNO1. That data show that the anti-EBNO1 comes first. And there's also the pleiotropy doesn't look like it works. There might be confounding and error, and we'll have to work through those issues as we go forward. So that gives you the picture of this end of the model for what we have for how lupus is developed. Anti-EBNO1 is strange. You usually don't develop antibodies until later in the infection. And why is that? It turns out that there are a whole host of different ways that anti-EBNO1 avoids the immune response. It is nuclear location, inhibits its digestion. It has this GA repeat, glycine alanine repeat, huge in the molecule that's repeated. And and gives the proteasome that presents peptides on the surface of the cell, constipation for that particular antigen. And there's GG stacking that inhibits RNA processing. And so the anti-CD8 response against EBNA1 is like two logs lower against that antigen than it would be against a similar antigen without the GAGA repeater. And so when we look at where the cross reactions are, in the molecule, they tend to be in either the N or C terminal region. And this has also been shown in multiple sclerosis. And so if you add the multiple sclerosis, all the multiple sclerosis cross reactions we've been able to find happen in this little region of the molecule. And so it looks to us as if this cross reaction business with anti-EBNA1 probably works in both diseases. And then when reviewing the literature, it looks like maybe this happens in preeclampsia, which would really be interesting. I chased these authors down, and the whole group disintegrated after this paper was published. But it would be a lot of fun to see if this is really true, that there's a component of preeclampsia that turns out to be an autoimmune disease. And so we have this model of how things are put together and how lupus operates. If I get to talk to you again, I'll tell you about the genetic piece that we think supports this idea of how it's put together. And so, you know, why is EBNA1 such a strong candidate? You can make, the human immune system can make 10 to the 15th different molecules. That's a huge number. Almost any structure, you can make an antibody that will bind it. And having one that is misplaced, it's like, you know, multiple sclerosis, you probably don't need more than a few B cells that do it. And so it's a situation in which you have a protected environment in which you make a very few antibodies that diffuse and then destroy nerve cells. And lupus is this huge systemic response. Those octolonies I showed you in the beginning, some of those patients can make 80 milligrams of antibody per mil. I mean, just 5-7 times more than the normal upper limit of normal for antibodies against one specificity. So the immune system is really out of control. Here's the virus with, you know, it buds out of the cell and has this plasma membrane on it. It's survived with us for, it's estimated 20 million years. All the higher primates have their own variant of this virus at this point. And so the idea is we take the genetics, put it together with the environment, and try to develop a unified understanding that would lead to better diagnosis, prognosis, therapy, and even prevention. As everybody in the audience wants to ask, well, why not make a vaccine against EBV? Well, people have tried, they don't work. The bottom line is that a normal person looks like they may get super infected with EBV. So how can you make a vaccine that's going to work to take advantage of the normal immune response if the normal immune response is not protective for super infection or different varieties? I have all these people to thank. Judy James we've been working together for 3 decades. Al Schofield, about the same. Ken Kaufman, all in the from the Oklahoma days, and then Dennis Clark, Yuri Chepilev, and Victoria Laranenka are more recent, and all of us are still working together. And all the different places that have helped put this work together and help us get closer to where this disease is coming from and to try to stop it from killing people in the future. Thank you.
Thank you, Dr. Harley. That's a lot of pathophysiology and immunology that most of us don't think of every day. But it's always my job to ask the nutrition question.
Well, my question to you is, what do we do with the microbiome to prevent this disease?
So that is actually the question. So
I wanted to beat you to the punch here.
You did it very well. And what generates the question is that if anyone looks at the International Journal of Disease Reversal and Prevention, a shameless plug, or that movie, Code Blue, that I'm
Yeah.
actually in the movie, but I was talking about heart disease because.
I can't wait to see your conflict of interest slide.
Zero, I don't take any money from anything that has a .com, so. But what's clear is that, there are so many case reports, almost just frustrating levels of case reports and books, case series of folks who went on a whole food plant-based diet and both MS and lupus
Mhm.
have resolved or disappeared completely. The one that you go on your search engine and look for the lupus doctor, Brooke Goldner, she was a medical student and was, had a creatinine that was gradually rising and she was on her way to dialysis and someone told her, well, just try a vegan diet and it all went away. Well, it's not that I'm a vegan denier, far from it, for heart disease, but the frustration is that if it's so powerful, why isn't everybody doing it? That's number one. The other is, what would be the pathophysiology if it's virus, as opposed to, the assumption is that when you change your diet, you're changing the microbiome, you're changing your immune response to everything, which means that it really has to be bacterial to some degree, or is there a lot of EBV in the GI tract that we're not tracking?
Okay, so thank you for your long question. The EBV story, if it's just EBV, you're only talking about a few percent of the epidemiologic risk. So you can say, okay, there's only 3% of what there is to explain. We've done that much. That leaves 95% of other issues that need to be contributed. It looks like the genetics makes maybe a 30% component. EBV plus this is in the other way I organize this lecture to basic scientists, is that the anti-EBNA1 cannot explain more than, with EBV as well, cannot explain more than 20%. That leaves about 50% of disease risk unexplained. The microbiome is a great candidate. There's other environmental effects. It may be that cytomegalovirus infection might be protective. It doesn't look like that's quite true, but it looks like it influences the autoantibodies that might be made. So there's a whole world, a whole universe left of other variables to explore to put the whole picture together. And so, I think you ought to be the PI on a clinical trial that takes all these patients that you have, and we're going to take people and randomly assign them to a normal diet versus whatever diet you happen to choose you think will work best, and see if, and then follow those patients and see what the difference is in the intensity of therapeutic intervention and their survival. So why don't we do that?
We should, absolutely.
So, thank you very much. I'm sure that our immunology people on the line have better questions than I do, but I was intrigued with the 30% false positive ANA, but then your slide of the biorepository showing eventually they may end up with lupus. So that brings to mind, we should be following people that have positive ANAs and occasionally plugging them back in to see when their row turns positive. That's one. So I can understand why people follow people with vague arthralgias and positive ANA, not that they know what to do with them, to your point. But it sounds like there's a second hit phenomenon then, and whether it's the microbiome, something that either upregulates your EBV antibody to the Epstein-Barr virus. There's something that upregulates it later on, whether it's another virus. And our rapid throughput hybridization just shows bacteria, to your point, Kim, but there's tons of viruses in the stool as well. And we don't have the ability to really categorize them, catalog them, figure out who are the bad guys and who are the good guys.
Okay, so
really
what is the question?
Yeah.
I lost the question.
The question was following people that are positive ANA, and
Okay.
do you think, since you just said I can only account for 20%, and 30%.
Yeah.
Do you think that the others are a second hit phenomenon later on? Which is also why people get more lymphoma when they get older, maybe. Something else happens that then causes that up regulation of the Epstein-Barr virus
So,
antibody.
first of all, I think there are fundamental differences between the female and male immune responses
Mhm.
that make a big difference. And so, the last common ancestor between mouse and man was like 76 million years ago, and both species have a dramatic difference in male and female immune responses. And so I expect that given that evolutionary pressure over such an enormous amount of time, there's probably multiple different ways that, and I have a lot of detail. I can tell you why that conclusion is right, but I don't have time. We can talk about that after, if you like. And so women have a stronger tendency toward autoimmunity to begin with, and every laboratory will set up their assays a little differently. And there's some laboratories where the positive ANA cutoff will only capture 2 to 5% of normal reproductive women, and others where it's 30%. And so being aware of that difference is a start. And then lupus tends to induce neuroticism in patients as a consequence of the disease. And so if you have a patient with a positive ANA who's also neurotic, then it raises suspicion. And so my approach is generally to reassure patients that come with a positive ANA referred by a generalist who I cannot find mouth ulcers, alopecia, rashes, or anything else. I say to them, and no family history or anything else that I usually reassure them and tell them not to worry about it. That if they are worried about it, to check in every 5 years or so with somebody, with a doctor that they trust, to see if they ought to be, if anything else happens, or if they have these symptoms that would refer to lupus. But I also know, on the other hand, that we have patients like the 16-year-old girl that I presented at the beginning who show up in extremis. You'll have patients walk into the clinic to see you as an outpatient waiting a month to get an appointment who are in renal failure without any other symptom. You'll have patients walk in who look like the world that they have rheumatoid arthritis. And you'll tell them, I've done this myself. Well, it looks like you have rheumatoid arthritis. I'll send off all the tests and you come back in a week and we'll reassess. And so they look classic. And they come and they send the tests off and they have a positive ANA and an anti-double-stranded DNA and no rheumatoid factor or anti-CCP. And you say, oh my goodness, here I've led this patient down the path. That doesn't happen very often, but happens enough that it's traumatic when it does. And so lupus patients can present with almost anything. I've had patients present with aortic stenosis or thrombocytopenia. Thrombocytopenia and hemolytic anemia are formed firsts. 2 years later, you can expect that patient to potentially come back, especially if they have anti-Ro antibodies with full-blown disease. So I don't know if I answered your question.
Oh, you did. I mean, it's like how to proactively follow people that before they become that extremist, and what do you look for?
Yeah.
You kind of said Ro, and it's one of the major ones, and also clinical signs.
So I have a bias. I think interaction with the medical system is dangerous, and that people should avoid it if they don't need it. And so,
Except here.
No, I
think we have,
There's a chat question if you wanted to pull it, or I can read it for you.
so please, if you would.
Okay.
I was just getting a lot of feedback when I was trying.
So the question is from Dr. Robert Emmons. He's in our our blood and bone marrow transplant group. He said, at Cancer Center Grand Rounds this week, and an investigator from Cleveland Clinic showed significant differences in myeloid-derived suppressor cells between males and females. Do you know of any literature on that cell population in SLE?
I do not. There's some, yes, I don't. There's a myriad of differences between male and female immune responses.
That's all it's on the chat.
Okay.
Yeah, that looks like that's the only one. Well, this has been an amazingly broad, investigation into, things that we all see knowing. We really appreciate your time and, the big surprise is you get it back.
Oh, I do. I got a slugger.
Absolutely. And, so thank
Right.
you very much. It's, engraved and
Yeah,
it's,
yeah.
hopefully you'll
Put this on the
treasure
back
it.
of my endowment.
Absolutely. But before you go, we actually